Top Bed Talk.
Nick Majerison here, and it's time for a conference highlight. This discussion is about the GIRFT, Getting It Right First Time project. Presented by Monty Mytham with his guest Dr. Michael Swart, consultant in anaesthesia and critical care medicine at Dore Bay Hospital and advisor to the UK Department of Health for the Enhanced Recovery Programme. It's one of our highlights taken from our coverage of the Royal College of Anaesthetists Anaesthesia 2018.
So, Mike, switching gears just a little bit, you are one of our national clinical leads, co-appointed by the Royal College of Anaesthetists and Getting It Right First Time, Professor Tim Briggs et al., orthopaedic surgeon.
And Chris Snowden in Newcastle
is the other national clinical lead, Chris Snowden from Newcastle. And so tell us just a little bit about what that role is about and what GIRFT, Getting It Right First Time, is trying to achieve.
Start with the college role first of all. I think our role is to facilitate and help others in the UK or internationally to develop perioperative medicine. Jumping to the GIRFT role, or Getting It Right First Time, is about using NHS data and any other data from things like the hip fracture database, the National Emergency Laparotomy Audit, to look at variation in perioperative medicine outcomes. What we will also be doing, in addition to just looking at that variation, is preparing individual reports for hospitals and then going to visit them to pose questions about variation that is associated both with good outcome, to find out what are they doing that gives them good outcome, and then also questioning where there may be not so good outcome and looking at, are there reasons for that less good outcome, and are there things that we can do to help them to improve outcome.
So fantastic. But if you take half the country each, Chris is in the northeast, you're in the southwest, are you going to get around all the hospitals between the two of you?
Yeah, I would like to.
Yeah, I'd put my hand up for that. If I had to,
I think I'd like to, because you learn a lot visiting places.
Yeah.
With the GIRFT projects, you produce a report.
Yeah.
From other specialties' experience, they found that you start with 2 to 4 initial visits to check your process, and then you start doing what are called deep dives, looking in more detail at places. And most people say that after about 30 visits, you've got an idea of what's going on.
Right.
Now, that may give us enough to start preparing a national report.
Yes.
But we will do as much visiting as they give us time for.
His previous experiences related to this, and people say he's not going to say enhanced recovery again, but I'm going to say enhanced recovery. If you go back to 2008, 2009, the visits were were on the edge of the cloud. So they were what appeared to be the people with the very best results, and what appeared to be the people who might possibly have much less good results as the sampling zones. And that seemed to clearly indicate that there were opportunities to do the same as the people on the cutting edge of the good results and draw the cloud across into that zone. Is it a similar principle, or is it?
I think it's a similar principle, but it's taking it a stage further.
Okay.
If you go back to the atlases of variation that have originally started from North America, John or Jack. I'm going to forget his name. Venom or not, Weinberg.
Right.
Jack Weinberg, I think it is. His ideas on mapping variation were picked up in the UK by Muir Gray, an epidemiologist from Oxford.
Yes.
And that led to the NHS producing atlases of variation that did nothing.
Right.
The difference that Tim Briggs has brought, working with Muir Gray originally, is a clinician visits and talks to other clinicians. So there is a face-to-face discussion.
Yes.
And you can't just have a book or a piece of paper or an email that you just dismiss.
And are you still, some of Tim's earlier presentations, I can't remember exactly how he phrased it, but there was sort of this unit of medical activity, the sort of cost of a day of care or a procedural type of thing that bundled everything in, including how much we're spending on salaries and equipment. And is that still part of the...
It will be. We haven't finalised. In the next 2 weeks, we're going to finalise what we're looking at.
Yeah.
But things that it is going to almost certainly be is looking at day case rates,
Right.
length of stay, readmissions, use of colloids,
Right.
and the costing of the use of those colloids. Hopefully we're going to be able to look at opiate consumption or opiate prescribing in across a whole health organisation. Yes. Now, with those, you can convert them to dollar or pound signs that could be potential savings. But I would put, probably the word is not savings, it's better use of resources.
Right.
And I think, we need to turn the way we look at healthcare in the same way that we look at the environment.
Yes.
We need sustainable environment, but we also need sustainable healthcare. We do have a limit of how much money our population is prepared to allocate to healthcare. And I think the getting it right first time process will allow us to optimally use that money.
Top Med Talk.
It's part of a longer conversation which you can find under the title RCoA 13, The GIRFT Project. Getting it right first time. Do remember you can meet the Top Med Talk team when we're going to be at the results of the Extreme Everest Symposium, June the 14th, live from Duke University in America. And of course, we're at all of the EBPOM meetings. Check out ebpom.org and find out how you can meet the Top Med Talk team.